All right, let's dive right in. Today, we're putting ourselves in the hot seat of a consultant viva exam. I'm going to be playing both roles for you, the demanding examiner and the on-the-ball candidate. Our focus, a critically injured polytrauma patient. This is going to be fast, it's going to be high yield, and it's starting right now.
Okay, here we go. Candidate, you're in the trauma bay. You've got a 28-year-old male driver in a nasty high-speed car crash. He is hemodynamically unstable. He's circling the drain. Tell me what you're going to do.
Thank you, examiner. I would approach this critically ill patient using the structured ATLS framework. My plan will cover, first, the initial assessment and resuscitation. Second, the critical decision-making process. Third, the key steps of a damage control laparotomy. Then, post-operative management and complications. And finally, I'll summarize the key viva points from this case.
So let's get right into it. The first few minutes, as we all know, can mean the difference between life and death. As the candidate, my absolute first priority is the primary survey. And in a real trauma situation, this isn't just some list you tick off. It's a dynamic, hands-on process to find and fix what's killing the patient, right now.
Okay, so I'd be verbalizing my actions as I go. First, A, airway with C-spine protection. Is the patient talking to me? If not, we're thinking about securing that airway immediately. Then, B, breathing. I'm listening to his chest. Are the breath sounds equal? Is the chest rising symmetrically? I'm actively ruling out a tension pneumothorax or a massive hemothorax. C, circulation. Now, this is where he's in real trouble. 2 large-bore IVs go in, we start a balanced resuscitation with warm blood, and we hit the button for the massive transfusion protocol. My main goal here is to find the source of the bleeding and stop it. Then a quick D, disability. What's his GCS? Get a baseline neurological status. And finally, E, exposure. We need to get all his clothes off to find every single injury, but at the same time keep him warm. We're fighting that lethal triad, acidosis, hypothermia, and coagulopathy from the very first second.
So as part of your circulation assessment, you throw the ultrasound probe on his belly for a fast scan. You see free fluid in Morrison's pouch. It's positive. Candidate, what is your definitive next step? My answer is immediate and absolute. Examiner, a positive fast scan in a patient who is hemodynamically unstable is a one-way ticket to the operating room. There is absolutely no role for any other imaging, like a CT scan. My next step is to get on the phone, activate the OR, and get this patient there immediately while we continue resuscitation. Time is everything here. Examiner, while we're making that move to the OR, my secondary survey is ongoing. For example, if I see bruising over the right lower ribs, that's a huge clue. As you can see here, fractures of those lower ribs, the 9th, 10th, and 11th, should make you highly suspicious of an injury to the liver or the kidney. And that lines up perfectly with our positive fast scan. It just solidifies my decision for surgery and tells me exactly where I'm probably going to find the source of the bleeding. So, with this patient, it's pretty clear we're heading straight to the operating room. But in a viva, you have to show that you've thought through all the possibilities. And that brings us to that big debate in liver trauma. When do you operate, and when can you safely watch? Let's play that out for a second. Candidate, let's just imagine that your initial resuscitation works, and the patient's blood pressure comes up for a bit. He stabilizes just long enough for you to get a CT scan. What specific things are you looking for to decide if he's a candidate for non-operative management or NOM? The criteria for NOM are strict, and you can't bend them. First, and this is the big one, the patient has to be and stay hemodynamically stable, not just for 5 minutes, but consistently. Second, you need a reliable abdomen exam. That means they can't have a head injury or be intoxicated, things that could mask peritonitis. And third, the CT can't show anything else that requires surgery anyway, like free air or a clear bowel injury. Our patient in this scenario already failed that first, most important test. And to show a bit more depth, I'd also mention that even if a patient checks those first boxes, some things on the CT scan tell you that non-operative management is likely to fail. Things like other solid organ injuries, a really large amount of blood in the belly, or any sign of active arterial bleeding, what we call a blush on the CT angiogram. These are all signs that the injury is severe and probably isn't going to stop bleeding on its own. Okay, candidate, the patient's stability didn't last. His pressure is now 80/40, and it's dropping, even with blood pouring in. You are now in the operating room, scrubbing your hands. Talk me through your operative plan. My plan is simple: damage control. This surgery is not about a beautiful anatomical repair. It's about physiology. The goal is to get in, stop the life-threatening hemorrhage, control any major contamination, and then get out fast. We'll fix his physiology, the coagulopathy, acidosis, and hypothermia, up in the ICU, and then bring him back to the OR for a planned second look in 24 to 48 hours.
So I'm making a long midline incision from the xiphoid process all the way down to the pubic bone for maximum exposure. The second I open the peritoneum, that tamponade is gone. So I've already warned my anesthesiologist to expect a big drop in blood pressure. We use 2 large suction devices to rapidly evacuate all the blood and clot. Then I'm systematically packing all 4 quadrants of the abdomen with laparotomy pads. This gives me temporary control and helps me figure out where the bleeding is coming from. And here's a critical point. When I'm packing that right upper quadrant, I have to be so careful not to pack too aggressively and compress the inferior vena cava. That would be catastrophic. It would just cut off venous return and make his shock even worse.
Candidate, you've placed your packs, but when you carefully take out the pack from the right upper quadrant to look at the liver, blood is just pouring out from a deep, ugly laceration. What is your next move to get vascular control? I'm going straight for a Pringle maneuver. I'll slide my left index finger through the foramen of Winslow, get behind the portal triad, and then just pinch the hepatic artery and portal vein against my thumb. This cuts off all the blood flowing into the liver. We can then put a vascular clamp on. And the second that clamp is on, the clock starts ticking. The liver can only handle this kind of warm ischemia for about 20 minutes, maybe 30 at a push, before you get irreversible damage. So we are super strict. 20 minutes on, 5 minutes off for reperfusion. No ifs, ands, or buts.
Okay, so with the Pringle on and the inflow controlled, I can finally see what's going on. If the bleeding slows way down, I know the problem is arterial or portal. If it keeps pouring out, I have to be really worried about a retrohepatic cable or hepatic vein injury. But assuming the Pringle works, I've got a few options. I can do a suture hepatorrhaphy using big, blunt-tipped absorbable sutures. For deeper lacerations, I can mobilize a piece of omentum and pack it into the defect, like a living patch. Or I can directly tie off any bleeding vessels I see in the wound. And for all that surface oozing, the argon beam coagulator is an absolute lifesaver. Excellent. You've managed to get hemostasis with packing, and you've put on a temporary abdominal closure device. The patient's now being resuscitated in the ICU. What are the key complications you're going to be watching for like a hawk over the next few days?
Post-operatively, there are 3 main things on my radar. First, an intra-abdominal abscess. This can form from dead liver tissue or a missed injury. The patient gets a fever, and we manage it with drainage. Second, a pseudoaneurysm. This is when an injured artery doesn't clot off properly and forms this fragile, high-pressure sac that can rupture days later. If I see a sudden drop in hemoglobin, I'm getting a CT angiogram, and the treatment is embolization by interventional radiology. And third, a bioleak, or what we call a bioloma, from an injured bioduct.
So if I suspect a bile leak, first we'd get a CT to confirm there's a fluid collection, and then we'd get a drain put in percutaneously. Now, if that drain keeps putting out a high volume of fluid, say more than 50 milliliters a day for a couple of weeks, that tells me it's a significant leak that probably won't close on its own. And that's our signal to call our colleagues in gastroenterology for an ERCP. They can go in, place a stent across the sphincter of Oddi, which lowers the pressure in the whole system. This basically encourages the bile to flow the right way into the duodenum and gives the hole in the duct a chance to heal up.
Okay, candidate. To wrap this up, give me a summary. What are the most critical, high-yield learning points from this case? What are the common pitfalls that a surgeon absolutely must avoid when managing a patient with a severe liver injury? What are your rules to live by? Absolutely. The crucial take-home points are these. First, hemodynamic instability is an absolute non-negotiable indication for the operating room. Never ever try non-operative management on an unstable patient. Second, in the OR, you have to be terrified of a retrohepatic caval injury. If you have the Pringle on and there's still massive bleeding, that should be screaming in your head. Third, don't forget the simple stuff. This patient is at super high risk for blood clots, or DVT. They can't get blood thinners yet, so you have to have mechanical compression devices on their legs from day one. And finally, a technical point. Don't kill the patient on the table by packing too hard and squishing the IVC. You can completely cut off their venous return. And the examiner leaves us with one last fantastic question to think about. When would you use angiography and embolization for this patient after the surgery? And that is such a great question because it really brings it all together. You could use it to treat a complication like that pseudoaneurysm we talked about, or you could even use it up front as part of non-operative management if the initial CT had shown an arterial blush. It's just a powerful reminder that modern trauma care is a team sport. Surgery, the ICU, and interventional radiology, we all have to work together seamlessly. You always have to be thinking one step ahead.